to talk on ultimate mimicker. Yeah.
Thank you. Thank you, sir. Thank you, AIS, for this opportunity. My topic of discussion is the ultimate mimicker. No financial interest. So, let the case begin with a patient who came to my OPD, 50-year-old female, presented with resistant unilateral conjunctivitis of the right eye. She had been treated elsewhere for 2 months with no relief. She was treated with topical antibiotics and corticosteroid for 1 month, but symptoms progressed. Detailed history reveals similar episodes over the past 3 years. So this is the eye. On examination, right eye and left eye, the right eye vision was 6/6 and left eye normal, and the lid and adnexa were normal. Conjunctiva, there was diffuse congestion, mild chemosis, no nodules or masses, lesions in the right eye, and the left eye was normal. Cornea, anterior chamber, iris and pupil were normal. And the fundus examination was also normal. The IOP was also normal. Ocular movements full in all directions, and there were no palpable lymph nodes. So conjunctival culture was done and no pathogen was identified. So, what should I do right now? I investigated, and the ESR came as 75 millimeters of mercury, HR, and Manto came as 20 millimeters, and HIV was negative. So further course, a physician consultation was sought in view of these findings. The chest X-ray and HRCT showed hilar lymphadenopathy. So a quantiferon TB gold test was done. It was turned to be positive, and she was not willing for any surgical procedure. Hence, conjunctival biopsy was not done. So in conjugation with the physician, and she was diagnosed with ocular TB, and ATT was started, and her symptoms started to improve in 2 weeks. The treatment was continued for 6 months. There was no recurrence now. It was a teamwork. Conjunctivitis is the most common cases we encountered in the OPD. Some cases may be resistant to routine treatment and needs further investigation to rule out underlying causes like tuberculosis or mass lesions. Although primary tubercular conjunctivitis is now a very rare entity, and it should be considered a differential diagnosis for unilateral chronic conjunctivitis not responding to treatment. Ocular TB is a clinical disease caused by Mycobacterium tuberculosis. The TB was various modes of transmission and can infect virtually any ocular tissues. Much like syphilis, ability to mimic multiple skin lesions, ocular TB should be thought of a great imitator of ocular pathologies. Globally, more than 1.7 billion are affected. Recognition of ocular TB as a clinical manifestation of extrapulmonary TB is critical, as a timely diagnosis can lead to early initiation of antitubercular therapy and prevent poor patient outcomes. Most cases of ocular TB are presumptive, getting histological or microbiological evidence of infection is extremely difficult. Also, the ocular disease may be due to direct infection or any immune reaction to the MTB. Uniform diagnostic criteria are lacking, and the interpretation of diagnostic modalities may vary globally. However, early detection and prompt management of cases with presumed ocular TB may lead to good outcomes. The patient may present with ocular redness, discomfort, mucopollen discharge with regional lymphadenopathy usually. Other conjunctival manifestations include subconjunctival nodules, flicton, ulcers, tuberculomas, or polyps. Tests for interferon gamma release assay and quantiferon TB are more specific, but false positive cases can occur in low endemic areas. A FNAC or a tissue biopsy attempt may be made, as the culture of MTB is the gold standard diagnosis. Demonstration of acid-fast bacilli also confirms the diagnosis of TB. However, the samples are difficult to collect, impose significant risk on patients, and the culture results may take up to 10 weeks. So in conclusion, chronic conjunctivitis should be evaluated thoroughly to rule out underlying systemic causes, especially TB in India. These are my references. Thank you.
Really, again, I was in that hall and telling that something like this is their eye-opener again, that tuberculosis is there in this country still and in world over again recurring. And like my wife was in gynae, and any infertility not responding to anything, she will give anti-tubercular treatment. And they would respond. So this is true of these things also. That even if you don't make a 100% diagnosis, a therapy of anti-tubercular treatment for maybe few weeks would start making the difference. So it's a good presentation, and I think again good education for students.
Yeah. I think rightly said, we should be aware that tuberculosis is still rampant in our country, And the commonest presentation is because of hypersensitivity in the form of flectin. But we were taught in our undergraduate, the only two causes of tuberculous conjunctival ulcer, one is TB, other is foreign body. So if there is a conjunctival ulcer, you have to rule out tuberculosis. And of course, the other forms are nodular, polyform, which are very uncommon. I have never seen. But another thing you said, culture is difficult. These days, they don't rely on TB. People don't rely on culture. They do a test called Gene Expert. So these are some things, but I think it's a...
That gold, even that gold
Quantafron.
test is not, I think gold quantafron also is now no longer...
It is done for extrapulmonary tuberculosis, they depend on, because MON2 is not available now. Unfortunately, MON2 test is not available because tuberculin...
कुछ लैब कर देती है
बिहार में है अभी
बिहार में
प्राइवेट लैब
मुश्किल से हो रहा है
कर देते हैं मतलब मैं अपने हॉस्पिटल में भेजता हूँ तो प्राइवेट लैब्स वाले कर देते हैं
Okay.
Actually, we rely on presumptive diagnosis as well as IGRA as well as mostly, and sometimes we get a very good clue of lymphocytosis. लेकिन यही है कि this is regarding extrapulmonary tuberculosis. It's a big headache for us to I think throughout the country to force the pulmonary medicine people to start the ATT.
They are
They are very reluctant to do this. I think it's a universal phenomenon.
don't start.
But now I have succeeded somehow. I actually write why we are very, very sure why it is this tuberculosis and tuberculosis and nothing else. So we are able
Yes,
to cope
madam.
with that.
I had that difficulty too. I had to call and phone him, like we will start.
Nobody, none of your pulmonary friends will help you in this regard. कि भैया ATT शुरू कर दो, इसका vasculitis हो रहा है, इसका uveitis हो रहा है, इसका chronic conjunctivitis हो रहा है. You have to really convince them. ठीक है. That was a very nice presentation actually. So now can we have the next speaker? Yeah. Dr. Harinder will be talking about on microcornea with advanced cataract handled with care. Is he around? No, he's not around.
Aditya
Okay.
Raj
ये लिखा हो मैं ऐसे आ गया खाली बैठा था मैं
से बाहर निकल के है ना LR वाले हो वो सारे वहीं पे हैं
My topic is on guarded use of steroids in case of injury to eye by vegetative matter. Traumatic cataracts can be a result of diverse injuries ranging from mild blunt trauma, which can result in a focal asymptomatic lenticular opacity, to severe penetrating lesions caused by a sharp object, which can result in total destruction of the lens and the surrounding structures. They require cataract extraction sooner or later, secondary to a perforation repair. Infection and endophthalmitis following an open globe injury are common. Endophthalmitis is an increased risk, especially if the environment in which the trauma occurred involves an organic material. Surgical outcome is limited by the associated ocular structural damage that occurs with the initial trauma. Post-operative management of such traumatic cataract includes topical antibiotics, steroids and cycloplegics to reduce the post-operative inflammation. In this study, we had performed cataract extraction of such a case of a traumatic cataract with history of injury by vegetative material, that is wood, after 12 days of the injury under antibiotic and antifungal cover, and started on topical steroids post-op under close observation for the signs of the corneal wound infiltration for a 3 months duration. The case is about a 35-year female who presented with injury to right eye by wood 12 days ago. The visual acuity was PR full with 3 mm full thickness sealed corneal perforation with no signs of stromal infiltration at the wound site. There was anterior capsular rupture with traumatic cataract formation and lens matter dispersed in the anterior chamber. B-scan ultrasound revealed no abnormality and KOH mount was performed, which was negative from the corneal scraping. The other eye had 6/12 vision with a history of amblyopia and a normal fundus. The patient was started preoperatively on topical fortified amphotericin B eye drops, vancomycin and fortified ceftazidime drops 2 hourly, natamycin eye suspension 2 hourly, and intraconazole ointment and atropine ointment twice a day. This is the preoperative picture showing a full thickness 3 mm sealed perforation with anterior capsular rupture and lens matter in the anterior chamber. The patient was operated for cataract extraction and lens matter wash with PCI implantation after 7 days under the above mentioned treatment. The lens matter wash was done using Simcoe's 2-way cannula. Can opener capsular exis was performed. Cataract aspiration using phacoprobe followed by foldable IOL implantation was done in the ciliary sulcus. On the post-operative day 1, the visual acuity was 6/12 with a healthy corneal wound, few flare cell reaction, and in-place sulcus IOL and normal intraocular pressure. patient was started on moxifloxacin and dexamethasone eye drops 1 hourly and prednisolone eye drops 1 hourly in a 7-day tapering frequency, and the patient was monitored for any signs of stromal infiltration or infection at the site of the perforation wound. On the postoperative day 1 and day 30, the picture is shown the wound is healthy despite giving steroids. And we can conclude that after the 3 months follow-up, there was no infiltration or infection at the wound site, and we can manage such cases of traumatic cataract post-operatively with the use of steroids and a topical antifungal cover, which can help to reduce the inflammation and promote early recovery, along with a perioperative antimicrobial cover adequately given, cataract extraction with all the precautions possible, and a meticulous post-operative monitoring. And in this way, we can diagnose and aid in the early management of infective complications of penetrating injury to eye, such as wound abscess and exogenous endophthalmitis. Thank you.
So, when was this cataract surgery undertaken after starting?
After 1 day, sir.
Just 1 day?
Yes, sir.
But post-operatively, I noticed you had stopped antifungal totally.
Yes, sir. It
Why?
was.
And you had started on natamycin, amphotericin, itraconazole, all 3. Why? You should do KOH and find out whether it is filamentous, non-filamentous. Accordingly, you should decide whether to give amphotericin or natamycin. But you had given cocktail of all antifungals. That means if even after 1 day you could do surgery with antibiotic steroid, so there was no fungal element at all. Otherwise, starting of steroids, the fungal infection would have really flared up. So, although the result was good, but the method is incorrect. So you should not give cocktail. You had given vancomycin, everything. But you should carry home this message: no cocktail, because the patient will have toxicity to so many drugs. Give only the targeted therapy. Right? Thank you.
Just one word to, again, what this girl has done, and I agree with her. People say that if you have got a can opener, you cannot put the foldable lens. It's absolutely nonsense. I have been putting that. Only thing is that your axis can opener should not have gone behind, should have not crossed the
Equator.
and your lens will stay. Because lens eventually will find the place to go and spread the capsule. If capsule has not ruptured or not spread back, it will stay. So you can safely do.
Dr. Sushma, please be ready with your presentation.
Please,
You
the next
can
speaker
come
should be ready with the presentation. Dr. Lippi, can you join us on the dais? Your moderator for our session.
Dr. Sushma, are you coming up? Yeah, please come up. She'd be deliberating on a tail of intraocular intruder.
Is on intraocular foreign body. A 32-year-old male came with the complaints of diminution of vision in the left eye since 1 month following an injury. Patient reported that while working, he was struck in the left eye by stone fragments. He experienced immediate pain, redness, blurred vision. He was taken to a local clinic where a scleral wound repair was performed, but he was not informed about any retained foreign body. Past medical history is not significant. Personal history is adequate. General examination, patient is conscious, coherent, cooperative, and oriented to time, place, and person. There is no evidence of pallor, icterus, cyanosis, clubbing, lymphadenopathy, and edema. Vitals are within normal limits. Systemic examination, nil. Coming to the ocular examination, vision in the right eye is 6/6, and anterior segment is normal. Coming to the vision in the left eye is hand movements. Lids are normal. Conjunctival congestion is seen. Corneal edema with 3 sclerocorneal sutures at 5 o'clock with nebular opacity at 6 o'clock is seen. AC flare was present. Iris hole at 5 o'clock, and pupil was irregular. Lens details were not clear. Fundus, there is no view because of VH. IOP in the left eye is 17 mm Hg. This is an intraocular foreign body with thin VH. Coming to the investigations, on B scan, there is low to moderate dense dot-like membranous echoes in the vitreous cavity, suggestive of VH. Incompletely bloodstained PVD was seen. RCS was normal. The CT scan showing you the foreign body here. Foreign body is noted here. CT scan was showing a foreign body in the intraocular aspect of the vitreous image measuring 5 into 6 mm. Management, We have done left eye pars plana vitrectomy with the foreign body removal followed by silicone oil infusion with cryo with wound suturing at 11 o'clock was done under local anesthesia. Post-operative day 1, vision is CF 2 meters, wound was healthy, superior temporal SCH was there and corneal sutures at 5 o'clock, and pupil is under drug mydriasis, fundus SOFG and retina 1. A discussion, intraocular foreign bodies varies in presentation, outcome, prognosis and depending upon the various factors. Intraocular foreign bodies can cause perforating and penetrating open globe injuries. The location and damage caused by intraocular foreign body depends upon various factors including the size, shape and composition of the object as well as the momentum of the object at the time of impact. Foreign bodies can cause direct damage. Subsequent damage depends upon the composition of intraocular foreign body. Iron and copper foreign bodies can cause cirrhosis, bulbar, and chalcosis respectively. Inert substances such as glass, stone, and plastic are better tolerated than metals such as copper and iron. Metallic and magnetic objects are most common intraocular foreign bodies. Organic materials such as vegetable material or cilia can cause severe tissue reactions and are highly contaminated and associated with significant risk of endophthalmitis. Mechanism of entry and size of objects are also factors in extent of injury. Foreign bodies entering the sclera usually cause more damage than those of entering through the cornea. High-speed small foreign bodies will cause small linear lacerations, that is less damaging than blunt trauma. Large irregular intraocular foreign bodies, however, cause an insignificant initial damage. Prognosis, outcome depends upon severity of inciting trauma, material location and the foreign body. Anteriorly locating foreign bodies without penetration of globe and good visual acuity on presentation were associated with better prognosis and visual acuities. Studies have shown that in cases with no globe involvement, no subsequent loss of vision were observed. Organic material have increased the risk of endophthalmitis, CNS infection. Surgical removal confers its own set of complications, including endophthalmitis, retinal detachment, and proliferative vitreoretinopathy. Studies have found no decrease in vision following surgical intervention. Post-operative loss has been reported at the rates of 2.5 to 4%. Conclusion, prompt recognition and management of intraocular foreign bodies are the vital in preventing permanent visual loss. Awareness of occupational hazards and use of protective eyewear can mitigate the risk of the injuries. Thank you. These are my references. Thank you.
Yeah, so a quick question for you. For this benefit of audience, can you tell the house which intraocular foreign bodies they need particular attention? Like after 3 months, 6 months of trauma, that patient needs to be really followed up. So which intraocular foreign bodies you think they need to be attended to very carefully?
Any vegetative matter?
Dr. Dorilal is next. Please be ready with his presentation, with your presentation.
More than that, we have chalcosis.
Okay, sidrosis.
Yeah, and sidrosis, yeah.
Iron
So those
iron and copper materials. Copper material.
They will be, keep on releasing for a long time.
Causing more inflammation. Right. Okay. Thank you. So next presenter.
Next presenter is Dr. Dr. Lipi, we can have your presentation next.
Good afternoon, everyone.
Last minute we can have Ashwini.
I am going to present a case on Usher syndrome. A 23-year-old female came with a complaint of diminution of vision for 2 years, which was insidious in onset and gradually progressive and painless in nature, and which was more during the night. She had a past history of difficulty in hearing since childhood. There is no significant family history, personal history, and no significant ocular history. General examination and systemic examination were normal. On ocular examination, she had a normal head posture and no facial asymmetry, and her best corrected visual acuity of right eye was 612 and left eye was 6.9. On anterior segment examination was normal. with IOP is normal. And on right eye fundus examination, media was clear, optic disc pale disc is seen with CDR of 0.5, and arterial attenuation with AV ratio of 1:3, and sclerosed vessel is seen in inferotemporal quadrant. Pigmentary changes are seen on macula, and bony spicules are seen in periphery in all quadrants. On left eye fundus examination, media was clear and pale disc was seen with 0.5 CDR, NRR healthy, and arterial attenuation was seen. And pigmentary changes were seen on the macula, and bony spicules seen in periphery in all quadrants. A provisional diagnosis was made as retinitis pigmentosa, both eyes retinitis pigmentosa. And visual field examination was done by confrontation test. Both eyes visual field restriction was seen in all quadrants, which was confirmed by HFA. The ring scotoma is seen, and tunnel vision is seen in the 10-2. And audiometry was done, and moderate to severe sensory neural hearing loss was seen in both the ears. And both eyes, Usher syndrome type 2 was a final diagnosis. And pedigree chart was drawn, in which all the other family members do not have any disease. So and we explained the nature and progression of the disease to the patient, and prescribed glasses and hearing aids to the patient, and genetic testing was advised, and counseling was given to the patient. In blood relatives and kids were advised for the eye examination to find out whether disease is present or not, or retinitis pigmentosa. And vitamin A was given, and she was advised to have a diet with lutein and zeaxanthin. Discussion. Usher syndrome is a rare autosomal recessive genetic condition that is characterized by progressive vision and hearing loss. 13 genes and 16 loci have been found to contribute to Usher syndrome. It has been classified into 3 major types based on the genes responsible and onset and severity of signs and symptoms. Type 2 is the most common, with moderate to severe hearing loss, with RP onset in second decade and normal vestibular function. In type 1 is most severe and with absent vestibular function. And type 3 is the rarest, with progressive hearing loss and variable vestibular dysfunction. Conclusion: Usher syndrome is a rare disorder with vast clinical and genetic heterogeneity, typically resulting in significant dual sensory loss, causing great impact on patients' quality of life. It is currently incurable. However, gene therapy is one of the potential treatment modalities that are being researched and developed for potential future cures. Take home message: any patient with retinal degeneration suspected of even slight hearing loss must receive audiological evaluation and treatment to minimize the effect of major sensory problems that arise from combined hearing and vision deficits. Thank you.
Yeah, doctor, a quick question. As shown, other relatives in the family did not have any syndrome of RP or Usher. So why is that so?
They might be carriers. They might be carriers.
Yeah, so inheritance of RP is actually interesting. It may be AD, AR, or X-linked. And Usher is, what I remember is that
autosomal recessive.
Yeah, autosomal recessive. Yes, so that's why. Okay.
Do you know of another syndrome with hearing defect as a component, along with ataxia?
Ataxia, ma'am.
That's how you distinguish it from Usher's, actually.
Yes, ma'am.
Okay, you can go and read that up. Okay, let's go. Now I would like to invite Dr. Lippi for her presentation on calotropis-induced toxic keratouveitis.
Induced toxic keratouveitis. This is something which is quite common in Chhattisgarh and also, as I know, in northern India. No financial disclosures or conflict of interest. Exposure to the latex of calotropis, procera or gigantea, these are the 2 common forms. This is associated most commonly with keratopathy in the form of corneal edema and escase. Ocular manifestations that occur because of 2 reasons: acidic nature of milky sap and toxins present in the sap. Case report. Female patient, 60 years, presented to ophthalmology OPD with complaints of sudden DOV in right eye after rubbing eyes while plucking furhar flowers. So these are the varied names, furhar and madar, arc. These are the names given to calotropis. I had undergone a small incision cataract surgery by resident of our department 3 months back. So this is what compounded the diagnosis a little for the resident. So the right eye vision was counting finger close to face. Anterior segment showed corneal edema, SKs, epithelial defect, hypopyon, pseudophakia. 3 months back only surgery had happened. Left eye 624 because of immature senile cataract, 16 millimeter Hg, and it was quiet. This was a pic which was taken one day after the presentation, because on the day of presentation the patient had come after OPD after 2 p.m. and a pic could not be taken. Patient was not cooperative. So this is one day after pic. Hypopyon has reduced a little because the resident did not start on steroids because of epithelial defect, and of course she was feeling it is end off. More of she was feeling it might be end off. But then telephonically I told her to start when I heard about the history. So hypopyon has gone down because of that weak steroids were started. So this is the right eye, big epithelial defect, and this is the left eye. So right eye was treated with topical lubricating eye drop, lotiprednol, tobramycin because of that epithelial defect, and dipenthanol gel, oral vitamin C, supportive tablets and medication. Hypopyon reduced and cornea improved after 3 days. This is a pic after 3 days, these two pictures. So fluorescein stain, we can see the epithelial defect has lessened. Hypopyon, it disappeared at 2 weeks. So after 5 days, when epithelial defect improved, lotiprednol antibiotic drop was substituted by prednisolone and gradual improvement. So at 2 weeks, we can see that hypopyon is completely gone. It was a very slow improvement because mostly what I have read in literature, it improves in 2 weeks, 3 weeks, but because there was so much of inflammation, so 3 weeks the picture was something like this, 4 weeks it is slightly improving. At 10 weeks, we are finding a corneal opacity, central corneal decompensation, and corrected vision came to be 6/36, minor correction. The resident had only operated this case, the resident who attended the case. And patient was advised specular microscopy for right eye, which is not there in my Government Medical College, and cataract surgery for left eye. So, quick discussion. Toxic iridocyclitis due to calotropis has been reported in literature. This could occur if the quantity of sap instilled in the eye is more, or if it was not immediately and thoroughly washed off by the patient. Sap has been found to contain certain substances that may lead to iridocyclitis. This is the pic of that same calotropis flower, which the attender was obliged, the attender brought after fourth or fifth visit. He brought this flower from his adjacent area from where the patient had plucked it. So to conclude, accidental contact with calotropis plant may lead to varied forms of ocular toxicity. So this is not only keratopathy, which many of the residents or young ophthalmologists, they think it may be a high-grade inflammation also with hypopyon. So this case seeks mention as uveitis is not a well-known feature of calotropis latex trauma. Being recently operated, it's 3 months back, hypopyon confounded the diagnosis and required cautious observation. Health education like washing of hands, avoiding contact or rubbing of eyes while plucking of these flowers is important to prevent this kind of injury. These are my Indian references. Thank you.
So all flowers are not safe. The flowers need to be careful about flowers.
Probably, used for...
Kaner, yeah. Shivji.
So, good afternoon all. I am going to present my case on inert vegetative intraocular foreign body of 10 years duration. There are no conflicts of interest or financial disclosures. Ocular trauma is more prevalent in children, with vegetative matter, like wood, being the most common. Retained foreign bodies may cause significant visual and anatomical disturbances depending upon the nature and site, and removal within 24 hours is recommended if accessible. So a 13-year-old male presented to our OPD with complaints of sudden painless diminution of vision in the right eye for the past 10 days. There was a history of seeing flashes of light. There was no history of recent trauma or surgery. There was a history of trauma to the right eye with a wooden object 10 years ago, for which the patient underwent corneal tear repair, followed by cataract surgery with PCL implantation. So on ocular examination, the uncorrected visual acuity was, there was accurate projection of rays in the right eye. There was no improvement on vision with pinhole. The intraocular pressure was normal in both the eyes. On further examination, the extraocular movements were full and free. And in the iris, there was a foreign body incarcerated in the inferonasal region near the pupillary border at 5 to 6 o'clock with sphincter tears. The pupil was sluggishly reacting and non-dilating. The lens, there was presence of PCIL with capsular phimosis. And on fundus examination, the media was hazy with discrete disc margins. The CDR was 0.3:1, and the retina showed a corrugated surface suggestive of RD. The details were not visible due to poor pupillary dilation. Rest of the findings were within normal limits in the left eye. B scan showed multiple dot echoes with single membranous echo in the vitreous with high reflectivity and moderate after movements. There was no CD. So based on these findings, the provisional diagnosis of right eye near total rhegmatogenous retinal detachment with iris foreign body with pseudophakia, status post-traumatic corneal tear repair was made, and the patient underwent right eye foreign body removal with syneculysis with PPV, endolaser and silicone oil injection under general anesthesia. So these are the intra-op findings. We removed a foreign body of approximately 10 mm in size. On post-operative day 1, the visual was hand movement close to face with accurate projection of rays. There was presence of air in the anterior segment with PCIL in situ. The posterior segment examination revealed a hazy media due to silicone oil filled globe. The retina was on, and the patient was started on topical medications with oral antibiotics, and strict prone positioning was advised. This is a picture of follow-up after 2 weeks. The vision had improved to 2/60. The anterior segment shows PCIL in situ, and the posterior segment showed on retina. So intraocular foreign bodies should be suspected in all cases of open globe injuries, and pre-op evaluation should include a focused history to determine time and mechanism of injury along with composition of the object. A careful examination with minimal pressure of the globe, minimal pressure applied to the globe is essential. Gentle B scan can be done by experienced personnel. CT scans aid in identifying the objects and further evaluating the globe or vital bones and planning surgery. The goal is to achieve best visual outcome possible by identifying and closing the entry and exit sites, reconstructing the eye if possible, and if possible, removal of the object. Ideally, the foreign body should be removed within 24 hours of the time of injury. However, in certain cases, we can wait if there are no signs of end-off and the vision is fine. So in such cases, we should do regular follow-up using vision, slit lamp examination, serial ERGs. If the ERG shows deterioration, immediate surgical intervention with removal of object is required. And to decrease, there is a high incidence of endophthalmitis with intraocular foreign bodies. So to decrease the risk, topical antibiotics can be given, and intravitreal vanco or ceftazidime can be administered. So to conclude, position of intraocular foreign body depends upon the velocity and type of foreign body. As with metallic foreign body, high velocity tends to penetrate deeper. With non-metallic foreign body, there is low velocity and it does not penetrate as deep. The retained IOFBs can lead to peripheral vitreous traction and adhesions, which can be a reason for late onset RD, as in our case. The prognosis, whether intervention is early or delayed, depends upon the mode of injury, site of retained IOFB, and type of foreign body, besides other host factors. And even though it is rare, vegetative foreign bodies in the absence of infection can remain inert for years, and proper timely follow-up can prevent delayed onset complications. Thank you.
I think indeed we have to be very careful with intraocular foreign bodies, and just a footnote that he's from my institute, so we have really been removing all sorts of foreign bodies from inside the eye. And one very strange thing that we removed very recently was, that a person had just gone, and that was a very long-lasting foreign body. We didn't even know that it was there, and then he had a chronic, inflammation. And then when we removed all the fibrosis around it, then inside it we found a foreign body. We just lasered the wound, and we decided to remove it, and we did. Okay, so let us have. Do we have the other speakers? Let me call out their names. The last call before we have, last but not the least, a presentation from Ashwini. Dr. Ashwini will be presenting on visual rehabilitation in hopeless conditions.
Next. So I am presenting several cases of miraculous visual rehabilitation, where with my visual rehabilitation, God's blessing, I could make patients see. That you can see Raghav had 11 years had visual acuity of hand movements only, that too close to face. On examination he had amblyopia, but his vision improved drastically to 6/36. Next, this person, he couldn't read properly, but with my visual rehabilitation, he had severe diabetic retinopathy, but with keychain magnifier, he was very satisfied. Next, and I am doing this also, visual artificial eyes I am putting. Next, this girl had near vision problem, but with Reiki reader, she could read properly. Next, this you can see how much her looks improved. Her vision could not be improved, but her looks improved. So this is my work, visual rehabilitation, which I have started in Bihar. So I need your blessings, all your blessings. But it's very tough to come here and with the paralysis and with a person. Thank you very much. कहाँ गए भैया? भैया कहाँ गए? चलिए भैया.
Not many people, I think, are aware. I think we should. I would not knowing that.
To continue the roll call, Dr. Komal, Dr. Harinder, you are there? Okay, in the nick of time. Dr. Shuaib, are you there? Okay, both of you are here. So, okay, so Dr. Harinder, can we have your presentation, please?
Yeah. Yes, so it is microcornea with advanced cataract.
Dr. Shoaib, please single out your presentation where it is, so that they can
today we'll talk about
save time.
Microcornea with typical complete coloboma with advanced immature senile cataract, handled with care. Myself, Dr. Hindra Dagar, Assistant Professor in World Medical College, Jhajjar, Haryana. First we will see a 57-year-old female, rural background female, housewife by occupation, came to OPD with chief complaint of gradual painless loss of vision since 2 to 3 years. History of present illness, diminution of vision since childhood, gradual painless loss of vision since 3 to 4 years, more associated in left eye than right eye. No history of wearing glasses, no significant personal history and family history. We will see the ocular examination. First we will see visual acuity, finger counting right eye and left eye hand movement, eyebrow and lid normal, cornea, both eye microcornea with vertical diameter in right eye 6.5 mm and horizontal diameter 5.5 mm. In left eye, vertical diameter is 7 mm and horizontal diameter is 5.5 mm. Inferior sclerization is also there. Just we'll look in the photo. Here, inferior sclerization, microcornea with coloboma, iris coloboma mainly. Retina is not involved. Conjunctiva is clear, anterior chamber mild shallow, pupil is reactive, keyhole pupil reactive to light but very sluggish. Iris coloboma in lower nasal quadrant in both eyes. In lens grading, both eye NS nuclear sclerosis with PSC. After dilatation with T-press drug, we will see fibrosis also there in anterior capsule in left eye. Rest all is right eye is normal, left eye media is hazy, that's why fundus could not seen. Extraocular movement, both eye nystagmoid movement is there with alternate convergent squint. We'll see in later slides. After examination, patient diagnosis with microcornea with typical coloboma with advanced immature senile cataract. B scan was done as media is hazy with no signs of RD, just mild vitreous liquefaction is there. Visual prognosis was explained to the patient and patient ready for cataract surgery. Then she planned for cataract surgery in left eye. These are the biometric reading of right eye and left eye. Corneal reading is normal in left eye, slightly higher in left eye and right eye normal. Axial length is normal, IOL power in left eye slightly lower. AC depth, AC is shallow, more in left eye than right eye. This is the B scan. This is the photo picture, patient left eye with microcornea with iris coloboma inferior typically. This is the patient photo after dilatation with advanced cataract. Now we planned for phaco, but as the case started, we found that there is capsular fibrosis at 12 to 8 o'clock and phacodonosis is also there. So we shifted to the SICS. Sclerocorneal tunnel was made, capsular access done, nucleus delivered, zonular dialysis. As we do cortical wash, capsular bag comes out. Because there is ZD 12 to 8 o'clock. That's why we can't make it good. And capsular bag come out at the time of cortical wash. No vitreous in AC, anti-vitrectomy done. Pupil is make vertical oval and case closed with 3 suture at the tunnel superior. This is the post-op photo with aphakia. Pupil is slightly vertical oval, 3 suture was there superiorly and case closed nicely with aphakia. Patient also having some nystagmoid movement. This is a video showing nystagmoid movement.
नहीं मेरी तो देर है, mine is late.
On next visit examination, AC was maintained, wound line healthy. As we seen, 3 sutures are there superiorly, vitreous behind the lens, iatrogenic hole at 11 o'clock at the time of cortical wash, inferiorly coloboma including disc and macula. After that we will see ki after aphakia we will see the fundus, then we will find out ki coloboma also involved disc and macula. Best corrected visual acuity in left eye with 660 with 10 diopter lens. Further management, we will plan those secondary IOL. For that we order special type of IOL, iris claw. We will plan for posterior iris claw IOL with specific dimensions just like 6 mm including haptic length. We will order for that. Patient counseling done for secondary IOL implant as we discussion. Cataract with microcornea and typical coloboma pose a great challenge for surgery, just like small size of cornea, shallow anterior chamber, difficulty in corneal incision, greater risk of complication during cataract surgery. Phacoemulsification thought not a contraindication but can be challenges. In these cases, zonular diagnosis, phacodonosis, poor pupillar dilation, capsular laxity also found. These patients having shallow anterior chamber and small cornea associated with glaucoma, congenital cataract and optic disc hypoplasia. Coloboma of the structures involved of eyeball leading to the visual impairment. These are my references. Thank you.
Yeah, an interesting case. We do find such cases, microcornea and coloboma. It would have been more interesting if you could have shown the final outcome after SFIUL and all was done, and also the fundus.
Yes,
and I would like to know, because the pupil was well dilated before surgery, so was there any phacodonosis or any evidence of zonular laxity?
Ma'am, we don't have any video for this.
You had the phacodonosis, no? But
yeah.
Okay, there was phacodonosis was there. Okay. Any comments from
I could do that, like I was doing them. We could make the people also round.
Yes, sir. We can.
You can really do the SICS without phaco or anything. You can cut the fibrous capsule.
Yes, sir.
And save that.
Can opener.
Capsule.
Can opener.
The question has come that once you really could not hold the capsule, and it came out and became a fakey. Definitely that is a problem, because these patients are so big hypermetropes that you finding a lens, you have to get ordered it somewhere special one. And I would do scleral fixation at the back rather than putting the iris fixation, because iris fixation is so fragile. I have seen that iris fixated lens falling in the anterior chamber or posterior chamber.
Yes, sir.
But the scleral fixation with the flap outside, but only thing is that you will have to get a lens that size, that number. So IO care can do make that. You can order them. But good one. These patients are common. You will come across in life like that. So they can be rehabilitated well. Thank you.
So
Thank
the
you.
next speaker is Doc. Yeah, so please come to the dais.
Good afternoon. I am presenting the case of living larvae wandering in the eye, a rare case of ophthalmomyces externa. What is known? Ophthalmomyces is the infestation of a dead or devitalized tissue of human or animal with fly larvae. These are generally found in the poor, neglected old person and with the lack of hygiene and with poor health. What is not known? A living larvae infesting normal vital eye in a young, healthy adult without any comorbidity and without close contact with animal. About the patient, our patient is a 20-year-old apparently healthy male presented to the outpatient department of the AIIMS Bhopal with the chief complaint of foreign body sensation and excessive watering of the right eye since 3 days. History of present illness: there is a history of dust falling in his eyes while riding motorbike 3 days back. No other significant ocular history and no other history of contact with animal. There are also no pain during extraocular movement, no loss of vision and no orbital inflammation. thus showing there is no orbital involvement. On ocular examination, vision of the both eye is 6/6. Extraocular movement is normal, and lid and adnexa are also normal. The conjunctiva of involved eye is mildly congested, and there in superior temporal fornix a wandering microbe with rapid vermiform movement seen. With 1:2 mm dimension, white in color with speckled pigmentation. There are a few petechial hemorrhage also seen. The cornea and the pupil within normal limit, and posterior segment examination was also normal limit. This is the slit lamp examination of that patient of involved eye with congested conjunctiva, and there is a microbe with rapid vermiform movement in the superior fornix with few petechial hemorrhage. Microbe was removed under topical anesthesia under slit lamp and sent for the microbiological examination. And further exploration under microscope, 2 more Rebling microscope were removed. And this is the wriggling dance of the larvae in the superior conjunctival fornix. The worm tried to move away from the bright light, and there is another worm which also trying to move from bright light and going to the fornix, and another worm is on the cornea. All these are removed on the topical medication and then sent for microbiological examination and identified as the first stage larva of Estrus ovis, which is also known as the sheep nasal boat fly. Management done by topical povidone iodine drop with ofloxacin and lotiprate eye drops. Oral ivermectin given 1000 mg as a single dose. In this duration, 3 more larvae was removed. Patient was kept on the same treatment for further 2 weeks. Patient was symptomatically better with visual acuity 6/6 in involved eye. Patient was kept on follow-up with which was uneventful. Do not forget, larvae shows negative phototaxics. They may be missed on slit lamp as they hide in fornices away from the light. Crucial to remove the larvae gently to avoid causing any damage to underlying structure, because they are strong adhesion to soft tissues by body spicules and the mouth hooks. Non-specific signs and symptoms entail a high probability to misdiagnose the case as acute conjunctivitis or episcleritis. In such scenario, larvae can potentially invade the deeper tissues and can cause significant inflammation, tissue damage, and secondary infection. Even though the patient may experience immediate relief, it is essential to have follow-up examination within the 24 to 48 hours to ensure that any remaining larvae in the conjunctival sac are treated or removed. This was seen in our case also when the larvae were removed on 3 subsequent occasions after the initial diagnosis. If any larvae are left behind, the initial treatment may not be effective. Despite the infestation into ocular tissues and inflammatory potential, most of cases are completely cured. Though a simple case, but worth your attention. Take home message. Not all red eyes are conjunctivitis or scleritis. Trauma with organic vegetative matter, even trivial, should be evaluated for any microbes, particularly ophthalmomyces. Careful slit lamp examination and though thorough wash of fornices with sterile normal saline after double eversion of lids is mandatory. These are my references, and thank you.
Yeah, this case is actually exactly similar to one of the cases which I recently saw in OPD. It also had about a 14-year-old boy. He was driving his moped, bike, and though without license and all, and got this about 20 to 25 larvae, and continuously I removed it for 3 days, and as soon as light is shown, this larvae they move very fast, so it's very difficult to remove them. So ivermectin dose was given, a single dose. I think it is sufficient, and then it can be repeated also, some people say. And the child also had 14 years, he had a vasovagal syncope while removal on slit lamp. So he fell down, then some time later he vomited, so all these episodes happened. So yeah, this is a ship bought only, then I went and I searched the literature. Yeah, so interesting case. Thank you.
Very good, and I just will comment that eye people, like eye surgeons, people will like see something like this, like seeing vasovagal or something. Recently I operated a lady and she came for examination, and then while examining her eyes like this, sitting on a bench, she went like this and fell down, death, but she did not die. So God knows, I am so scared of I feel like examination also, do you need anesthetist to examine someone? So they fall down like that. Another thing about that, every red eye is not conjunctivitis and scleritis. If there is no speaker, I will say my experience of one foreign body, one kind of I was in Yes, Safdarjung Hospital, eye department. One lady came with red eye, nasal. So just saw and Manica conjunctivitis, antibiotics, steroids, but it won't go away. Repeat examination, no history of any kind, she would not give anything at all. So one day just I started palpating here and I found a sharp thing. That Manica, red eye is because of this foreign body, but what it is? Then we did the CT and this was a long knife from here, came from sinus and saved the orbit wall के पास जाके वो nose में था, मतलब यहाँ आ गया था, nasal side of the orbit. And it was a stab wound, knife broke. It was nearly 4-inch long knife. And it was done by, this lady her son did it. Her son stabbed her mother because he wanted money for liquor. So liquor should be banned in Bihar and everywhere you have banned. So banning means death, so more early moksha. You can go up, meet with the God and be happy. There they have the better drinks, I think somras and all that. So why to be on this land, which you have so many attackers and so many people? There are all good people. No? Good. Thank you so much. Thank you so much.
Are there any more speakers? Any more speakers? No. So we conclude the session with a photograph. If the speakers are there, I request them to